So it's my greatest pleasure to introduce our distinguished guest speaker today, Dr. Sherif Nagueh, one of the world's foremost experts in cardiovascular imaging and a leading authority on echocardiography. Dr. Nagueh served as a professor of medicine and the medical director of the Echo Lab at Houston Methodist DeBakey Heart and Vascular Center, a globally renowned institution for cardiovascular care and research. And Dr. Nagueh is internationally recognized for his landmark contributions to diastology and non-invasive hemodynamics. His foundational research includes development of tissue Doppler and diastolic function assessment parameters now used worldwide. He has shaped contemporary clinical practice and is embedded in major international guidelines. Most importantly, the guideline that we use every day, he served as the chair of the ASE Guidelines Committee, offering many most cited documents, especially the diastolic guideline. And without further ado, I'm going to pass on to Dr. Nagueh to give us this introduction. And thanks for him joining us from Texas, which is an hour earlier than our time. So thank you.
Good morning to all, and thank you for the kind introduction. I'll talk about multimodality imaging of patients with hypertrophic cardiomyopathy, and I will try to highlight the clinical implications of the imaging findings. So one purpose of imaging is to make the diagnosis, and the diagnosis doesn't just depend on imaging, but imaging is a big part of that. Without it, one cannot make the diagnosis. It is well recognized that there are different morphologies that we see. There is the pattern of basal septal hypertrophy of that sigmoid septum. That's the pattern that is most frequently associated with dynamic obstruction. But these patients, if you do genetic testing, they do not turn out to have a high yield of pathogenic or likely pathogenic variants. In comparison, the reverse septal curvature that you see here have less likely findings of obstruction and more likely positive genetic yield. Individuals with this pattern present at a younger age, and as time goes by, they end up with worse outcomes, be it arrhythmogenic events in particular, but also heart failure at times. There is the apical hypertrophy pattern that you see up there, and with time that apical hypertrophy can thin and an aneurysm can form. Then there is mid-ventricular obstruction. The mid-ventricular obstruction is thought to be a potential precursor of apical aneurysm formation. Then a concentric hypertrophy pattern. This is the least frequent of all the different patterns that are present. Systolic function is important. It dictates treatment, as you will see in a short while. In the classic group of patients with hypertrophic cardiomyopathy, we use the beta blockers, the calcium channel antagonists, non-dihydropyridine calcium channel antagonists. In the presence of obstruction, you treat obstruction. But then there is a subset of maybe 5 to 10% of patients where, as time progresses, the wall becomes less thin, but not really thin as in dilated cardiomyopathy, and the ventricular dimensions increase. And though they increase, you do not see the large ventricles that you see, say, with dilated cardiomyopathy. In this phase of the disease, the ejection fraction will drop to the low 50s and lower, and here the outcome is much worse, more likely to progress to advanced heart failure treatments, and we do not use the usual drugs we use for the classic form of the disease, but the drugs you use for patients with heart failure reduced ejection fraction. So that's a key measurement by echocardiography to do ventricular systolic function by plain EF. Another finding in patients with hypertrophic cardiomyopathy, we're talking now classic phase primarily, is abnormal long axis function, and is exemplified here by a comparison between a normal patient and a patient with hypertrophic cardiomyopathy. You see global strain much reduced, 7% versus a value in the normal range. That reduction in global strain has been associated with heart failure events and in general worse outcomes. For labs that do sprain measurements routinely on all cases, it is encouraged to include it in the report. Aside from knowing what the global strain is, the polar map provides us insight with what is abnormal. These are two patients. One has the basal hypertrophy of the septum that you see here. And if you look at the polar map, the basal septum has much reduced strain compared to, say, the mid-segments and the apex. In comparison, in that patient with apical hypertrophy, the apical strain is much worse compared to the basal and mid-segments. Diastolic function assessment is of value or is of importance in this patient population because they frequently have symptoms of shortness of breath, even in the absence of dynamic obstruction. And we can detect different grades of diastolic dysfunction, if you would, in these patients. So early on in the disease, the main abnormality is the increase in left ventricular lead diastolic pressure, specifically end diastolic pressure, manifested here by that atrial velocity in the pulmonary veins of a long duration and a peak value approaching 40 centimeters per second. If you compare its duration to that of antegrade mitral inflow, the duration is longer, and that's a very good indicator that LV and diastolic pressure is indeed elevated. This is a common finding. I would say the yield of satisfactory pulmonary vein signals is quite high in the outpatient setting. As the disease progresses, patients with hypertrophic cardiomyopathy can end up with restrictive filling, so a very high E to A ratio. That arrow points to mid-diastolic flow or an L velocity that is occurring because LV relaxation is slow, delayed, and keeps happening even though filling is now taking place because of a higher left atrial pressure. If you look at the annular velocities, septal or lateral, these velocities are very small, with a very high E to E prime ratio. These individuals have a lot of symptoms of shortness of breath, a high likelihood of hospitalization for heart failure. Another finding that we look for or that we may find in patients with hypertrophic cardiomyopathy is dynamic obstruction. And if you look for it, it is present in roughly 2/3 or 70% even of patients. The cause of dynamic obstruction, and we will not talk much about the mechanisms today, is that systolic anterior motion of the mitral valve. On that mode, the arrows point to where the anterior leaflet touches the septum. Very nicely illustrated by 2D here. You see the arrow, and then we see acceleration of flow in that inverted Y appearance through the LV outflow tract and a mitral regurgitation jet, typically directed posteriorly and laterally, but can be a central jet in some patients. 3D is very nice in illustrating the presence of dynamic obstruction, as you see in this example. I will say that many times it is easier to recognize the presence of dynamic obstruction in challenging cases when you see live movies as opposed to someone freezing it and going frame by frame. The severity of obstruction is determined by the gradient, and we follow the modified Bernoulli equation. So we look for that peak velocity, and here you see the dagger-shaped, rather late peaking velocity that exceeds 4. It's actually closer to 5.1 with a very high gradient. It is possible for the sonographer, by changing the alignment of the ultrasound beam with the flow, to record the mitral regurgitation jet. And in this case, we are recording the mitral regurg. Notice that the peak of the mitral regurg is much higher, about 7.5 meters per second or so. And the dynamic obstruction signal is superimposed. Even though we see both signals, it is very difficult to just look at this and say what the peak velocity is. It would include a lot of guessing. So if we are showing that, or if we are acquiring the signal and showing that mitral regurg, we want to realign, we want to do a sweep to show the LVOT gradient by you see in this figure. Sometimes we deal with patients who have very high gradients, and the question comes, did I record the peak velocity of the gradient correct, or is there contamination with the MR-JAD and I am overestimating the severity of obstruction? In this case, we want to go to that peak MR velocity. And if we look at it and we say the peak MR velocity is 7.5, we make an assumption that the left atrial pressure is around 20. As you will see, that has a little impact on the final peak gradient. And then we measure the systolic blood pressure by the cuff. We make the assumption that the pressure in the aortic root is the same as the pressure we get by the cuff, which I know is not the case, but to do something practical, that's what we're going to work with. So we say the difference in pressure between the ventricle and the atrium is given by that modified Bernoulli expression, 4V squared. And since we know that the peak velocity of the MR is 7.5, we will say that the ventricular pressure is at least 225 millimeters mercury. So if we know that the pressure difference is 225 and we add the left atrial pressure to that, which is 20, we end up with a systolic pressure of 245. And now we go back, or we go in a different direction, the direction of the LV outflow tract, and we say the difference between the peak LV systolic pressure and the systolic blood pressure is equal to the gradient. We established the systolic pressure through that simple calculation at 245. That's the pressure in the ventricle. Systolic blood pressure is 170, and so the difference between them is 75 millimeters mercury, which means that the peak velocity of the LVOT flow signal should be somewhere between 4 and 4.5 meters per second. So that's a quick check that someone can do and be satisfied that I indeed got the correct value of the peak velocity and I'm not overestimating obstruction. Nowadays, you will see, and particularly if you're a referral center, you will see cases of obstruction that are not just dynamic obstruction, aortic stenosis. In the older days, transesophageal echo was looked at to do planimetry of the aortic valve area. Now we have options with cardiac CT that gives you an anatomic orifice area, of course, different from the functional orifice area we get by the continuity equation. You will see patients who have coexisting dynamic obstruction and aortic stenosis, as in this case. So this is the dynamic obstruction signal with Valsalva. The velocity is somewhere between 2 and 3, perhaps slightly more than 2.5 is the highest velocity shown here in that second beat. In comparison, if you look at the aortic stenosis signal, it's earlier peaking, much early peaking, compared to the late peaking, and the value is higher, around 4 meters per second. It's less, it's about 3.8 or so, or 3.8 or so. When we calculate the gradient here, it is incorrect to do the modified Bernoulli equation because of the proximal obstruction and the proximal velocity exceeding 1.5 meters per second. So we want to do 4V2 squared minus V1 squared. That figure to the left, to the far right of my screen, shows the two signals superimposed. The dynamic obstruction is pointed to by the red arrow, and then the aortic stenosis signal by the white arrow, albeit more faint. In these cases, we do not do the continuity equation relying on LVOT flow because of proximal acceleration. If you want to calculate the actual aortic valve area, you can do anatomic planimetry of the valve, or you can do 2D stroke volume and divide that by the continuous jet, the time velocity integral of the continuous jet, assuming there is no significant mitral regurgitation, which can be a challenge because these patients can have variable severity of mitral regurg. This is a patient who was referred with a diagnosis of hypertrophic cardiomyopathy, and then on the transthoracic there was concern whether there is something in the outflow tract. And here you see a subvalvular membrane, and if you look at the signal by continuous wave Doppler, it is more of a fixed as opposed to a dynamic obstruction. And you see some aortic regurgitation, which is uncommon in young individuals with hypertrophic cardiomyopathy, but much more common with subvalvular membranes. Because obstruction is associated with worse symptoms, and because when we treat obstruction, symptoms improve, we want to look for this item of provocable obstruction. And provocable obstruction can be provoked most physiologically by exercise. Amyl nitrite is used by some labs. Valsalva is now part of the routine protocol. So if I'm referring a patient to the lab with the diagnosis of hypertrophic cardiomyopathy, the expectation is the lab will not only show me the gradients at rest, and that will be reported, but also they will ask the patient to do a Valsalva, a good effort Valsalva, and they will also show the gradients with Valsalva. And both are considered by the treating physician in formulating a treatment plan. Squatting to standing can make obstruction worse. In the cath lab, there was time when isoproteinorb was used, not that nowadays, and dobutamine in some patients who cannot exercise. We don't want to go to high doses of dobutamine if that is the case. PVCs can sometimes happen during the scan, and if I am scanning and I recognize that there is a PVC, I want to obtain the Doppler signal to look for the post-PVC beat. But more frequently, it is readily recorded in the cath lab, as you see in this example. When the catheter in the ventricle is just moved a little, it can trigger PVCs, and you see the post-PVC very large obstruction. You see the decrease in the pulse pressure in the aorta, and that's the Brock-and-Brock effect, thought to be due to more forceful contraction after that PVC. This is an algorithm that was included in the American Society of Echo, which document in 2022 for the diagnosis of hypertrophic cardiomyopathy, focused on the role of imaging. It was a multi-society actually document led by ASE. If you have a symptomatic patient and you looked at the gradient at rest and with Valsalva, and if you're a lab that does amyl nitrite or squat to stand, and you are left with a gradient, a provocable gradient less than 50, we want to do exercise stress echo. If then there is SAM and the gradient is at least 50 millimeters mercury, that's enough to trigger the recommendation for treatment in someone who is symptomatic with that severity of obstruction. On the other hand, if it is less, these are individuals that you can reevaluate at regular intervals, and it is not uncommon to see a patient in a given year who doesn't meet that threshold, but they meet it on another day. As you know, the dynamic gradients vary with time, vary with activity, vary with intravascular status, vary with blood pressure. Even a postprandial situation can make the gradients worse. So these factors should be taken into account. And if needed, you can repeat the exam. We touched bases early on when we were talking about morphology on mid-ventricular obstruction and apical aneurysms. I will say these are not uncommon. In the recent NHLBI registry, looking at patients with hypertrophic cardiomyopathy and the relation of imaging findings to outcome, this morphology was noticed in 3% of the patients. Is significant, what we call obstruction, present with a gradient of at least 30 millimeters mercury. To be able to diagnose what is happening in the more distal part of the ventricle, distal to that mid-ventricular obstruction, you may need to use ultrasound enhancing agents. Cardiac magnetic resonance plays a great role in identifying these cases, and if you have doubt and the echo is not clear, then it is recommended that you refer them for imaging with cardiac MR. The finding of an apical aneurysm portends a higher risk for mortality and ventricular arrhythmias and can trigger a recommendation for an ICD implantation. So we do not want to miss the presence of an apical aneurysm. This is an example of a patient with mid-ventricular obstruction. You see the apical aneurysm. You see the acceleration of flow by color Doppler, and you clearly see in the apex a clot that is attached to the apex. This is another patient with an apical aneurysm, but shown by cardiac magnetic resonance, and there is an apical clot. The patient is placed on anticoagulants, and the clot is gone. Of course, the substrate that led to the clot is still present, and one can argue that these cases are safer managed with the ongoing use of anticoagulation. I want to talk now about imaging markers to identify patients with a high risk of sudden cardiac death. A maximum wall thickness of at least 30 millimeters is considered one of these findings. However, if you think about it and you say, what is my reproducibility of measurement? If you see a case with a thickness of, say, 28 millimeters mercury, that's also is in the same ballpark range where we want to say this is indeed a finding of a high risk for sudden death. Apical aneurysms and event rates of sudden death, fatal ventricular arrhythmias occur at 5 to 15% per year, so pretty high rate. The presence of late gadolinium enhancement that is more than 15% of left ventricular mass is associated with worse outcomes. At the present time, it doesn't have the same standing as the first two bullet points, but can modify the recommendation when you, with other findings being considered. And we'll sort of touch bases on that shortly. The European Society of Cardiology has a hypertrophic cardiomyopathy calculator for the risk of sudden cardiac death. And in that model, they look at the left atrial anteroposterior diameter as one of the inputs that puts someone at a higher risk of sudden cardiac death. I will say to you that atrial size is more related to events of atrial arrhythmias, atrial fibrillation, heart failure, perhaps much more than just sudden cardiac death. Dynamic obstruction is also a risk factor in that sudden cardiac death calculator. Again, obstruction is more related to heart failure than sudden death. On the other hand, an ejection fraction, 50% or less, is a major risk factor and is enough by itself to make the recommendation for ICD implantation. The presence of ischemia, be it with SPECT, PET, CMR, is associated also with a higher risk. This conclusion is based on small studies with SPECT in the older literature, and as such, they do not factor in the day-to-day practice, but be aware that these patients have ischemia, and it can be a cause of problems to them, be it angina, dyspnea, and potentially arrhythmias. This is the initial paper that looked at the relation of maximum wall thickness and sudden cardiac death in 480 patients. And while it shows that the risk is highest for individuals with a wall thickness of at least 30 millimeters, you can appreciate that as the thickness increases, the risk is increasing. So it's really a continuing risk. It's not above this value, we see all the problems. Below this value, we do not see events. And if you look at individuals who have sudden cardiac death events, the majority of them will not fall in that 30 millimeters cutoff. So we don't have to just wait for that value or focus on that value and ignore everything else. We talked earlier about the late gadolinium enhancement, which is a reflection of the extent of replacement fibrosis. And you see here an early study relating that late GAD enhancement extent with estimated 5-year event rates. Sudden cardiac death rate goes up, total mortality driven mostly by cardiac mortality, goes up, and as well as the end-stage hypertrophic cardiomyopathy case. And these are examples of late GAD enhancement. In most patients, you will see some degree of delayed hyperenhancement in the septum at the RV insertion sites, but you will also see a lot of GAD enhancement in thicker segments compared to segments with normal pore thickness. Example of apical infarction, if you would, where a lot of the muscle is gone and replaced by replacement fibrosis. I'll talk briefly about ischemia and CAD evaluation of patients with hypertrophic cardiomyopathy. This is a patient who had symptoms of chest pain. The physician requested a stress perfusion study with PET. And if you look at the apex comparing the stress with the rest image, the image has more perfusion in that apex of the ventricle, and as well as the lateral wall looks brighter. If you would, when you look at the apex in the vertical lung axis view and the lateral wall in the horizontal lung axis views. These perfusion defects turned out not to be due to epicardial disease, but is part of hypertrophic cardiomyopathy. These patients have a supply-demand mismatch many times. And if you look also at coronary flow reserve for the individual territories, it is reduced in these patients. Part of it is because the resting blood flow is higher, and since the flow reserve is a ratio, that ends up being reduced. So be aware of a stress test that is positive in someone with hypertrophic cardiomyopathy, particularly the apical pattern as I show here. Cardiac CT can play an important role in studying the epicardial vessels. So if we're looking for coronary atherosclerosis, certainly has a role. But aside from that, there are some unique reasons for this, for looking at the CT in this patient population. Sometimes we plan alcohol septal ablation, and you want to know the course of the septal perforator arteries and what segment of the septum it supplies. And that is nicely illustrated here with that arrowhead. Also, these patients can have myocardial bridges, as you see here. These vessels, the left anterior descending artery segment, and within that bridge gets compressed during systole and can be a contributor for symptomatic problems for these patients. Some surgeons will relieve that bridge obstruction. If we were to say, let's look at an approach of how to evaluate a patient with hypertrophic cardiomyopathy who presents with chest pain, we can follow the general approach that you see on this slide, which is also recommended for patients without hypertrophic cardiomyopathy. If you see someone with a low likelihood of disease, low likelihood is less than 15%, you can simply say no need for testing. And we are looking for non-coronary causes. If the pain is persistent and the patient wants something done, so to speak, you can do a coronary artery calcium score. And if there is zero calcium, that could end the situation because the likelihood that there is actual stenosis is very low in this scenario. On the other hand, if you have someone with an intermediate probability between 15 and 50%, we can start with coronary CT angiography if this is suitable for the patient, suitable in terms of renal function, doesn't have something in the way of looking clearly at the coronary arteries, and can take beta blockers for slowing the heart rate. Based on the coronary CT findings, if there is no plaquing, that ends the evaluation. Likewise, if there is less than 50% stenosis, if they have a high risk, more than 50%, that's when we proceed to angiography. Also, if it is non-high risk, but CAD probability more than 50% with symptoms, you can either consider a CT, fractional flow reserve, or you can refer them to the cath lab. If you look at intermediate to high probability And if you consider cases with intermediate probability who are, for technical or safety concerns, cannot go to CT, or someone with known CAD, we can do stress testing as the first step. The accuracy of detecting problems in terms of true ischemia is much better with PET or cardiac magnetic resonance imaging as opposed to SPECT or echocardiography. And so these are the preferred stressor modalities. There is severe ischemia, is straightforward for CAD. If it's normal or mild ischemia, you can say we observe. Moderate ischemia with ongoing symptoms, either you can take them to CAD, though you may consider a CT, coronary CT angiogram to look at their coronaries and, if needed, a fractional flow reserve. And I will say this is a general approach. Irrespective of hypertrophic cardiomyopathy, hasn't been specifically looked at in hypertrophic cardiomyopathy patients, but there are no reasons to expect a different performance. Now, imaging plays a key role in guiding the treatment of dynamic obstruction, and let's talk about how that takes place. So for medical therapy patients, we typically do interval imaging at 1 to 2 years or sooner if there are symptomatic changes. What is the objective of imaging in patients with obstruction? We want to know the gradient. We want to look at changes in ventricular size and function. As you saw, a small subset can develop the dilated hypokinetic phase of the disease, which dictates a different type of treatment with guideline-directed medical therapy for patients with heart failure reduced EF. For patients who will be prescribed myosin inhibitors, the regular echocardiograms are needed as part of the REMS program to look at the gradient, and the most accurate method of looking at ventricular systolic function is actually measuring EF, not a visual estimation, to detect subtle changes in EF, which may be noted on serial studies. Why we look for the EF and why we look for the gradients when we consider titration of the drugs is to avoid the development of heart failure with a reduction in the ejection fraction. We do not want to wait when the EF is less than 50% and there are signs of volume overload. Septal reduction therapy is guided by imaging, and this is an image taken from a patient undergoing myectomy. The purpose of imaging during myectomy is not just that there is obstruction and what the gradient is. It is to help the surgeon plan how much resection he or she needs to do. And here you pay attention, yes, to the thickness of the septum, as you see in that dotted line, but you also pay attention to the vertical extent. Why is that important? If the resection is only limited here to that very basal segment, but you do not resect more distally, the patient will leave with residual SAM, residual obstruction, and this is a major problem because now they have had open chest once. Post-myectomy, you can measure the thickness, which should be less, and you can describe the extent, if you would, aortic to apical direction of how much septum has been resected. We also use echocardiography to screen for the development of ventricular septal defect. This is an example of a patient who does not have a ventricular septal defect, and I would say with experienced centers, this is a very rare occurrence. Another important use of imaging is guiding alcohol septal ablation. And what happens during that procedure is that we have the balloon engaged into the left anterior descending coronary artery. The guide wire goes into the first septal, most proximal septal perforator branch. The balloon is inflated here. This is the guiding wire. This is the balloon. And through the lumen of the inflated balloon, alcohol is injected. Before we inject alcohol, we want to know what part of the myocardium is supplied by that first septal perforator. And here you can use, in the older days, we used Albunex, which is no longer available, Tesson, Levovisc. But nowadays, the actual contrast agent used to visualize the coronary arteries can be agitated and will allow for visualization of this basal septum. This is an example of a case where you see the basal septum highlighted, if you would, with the agitated contrast. We put color Doppler, and we see that where flow is accelerating is where the septum is hypertrophied, so we are in the right spot to target infarction to that segment. Because the septal perforators can supply the RV as well as the LV side of the septum, we want to recognize that. I'm showing examples here with transesophageal echo, but you can get similar results with transthoracic. We rarely do transesophageal echo to guide alcohol septal ablation. This patient has opacification of the LV endocardium, so the right location you want. On the other hand, in this subject, we see the opacification primarily on the RV side. This would not be a good septal perforator to target because we will induce infarction here, but not the LV endocardium where the SEM is involved. Sometimes septal perforators, particularly if you go away from the first septal perforator, can supply other structures. And this is an off-axis view showing opacification of the papillary muscle that was recognized, and the balloon was taken out of that septal perforator so as to avoid inducing papillary muscle infarction. And you can see other walls, the wall, lateral wall, depending on the origin of the septal perforators and the extent of collaterals. When done efficiently and successfully, alcohol septal ablation is very effective in improvement of patient symptoms. This is the septal perforator before alcohol injection, and this is after it is injected. That artery is completely gone here, where you see that yellow asterisk. The obstruction goes from a gradient of 115 to nothing. This is an early peaking velocity, not a velocity of obstruction. How about the effect on mitral inflow? So this is pseudonormal with a high left atrial pressure. This is an impaired relaxation pattern that goes with a much lower left atrial pressure than at baseline. Likewise, if you look at the peak tricuspid regurg velocity before the injection, the peak velocity was 3.5, corresponding to an RV and a PA systolic of at least 49 millimeters mercury. But after obstruction, the peak velocity is only 2.3, corresponding to a gradient of at most, or a PA systolic pressure of at most 21, of at least 21 millimeters mercury, pending the addition of RAP. So we see consistency in that the mitral inflow and the TR jet tell us that pressures are lower in the left atrium and can be very effective in symptomatic improvement. Another tool in the box that you can offer patients with dynamic obstruction when the septal thickness is particularly not conducive for septal reduction therapy is transcatheter edge-to-edge repair. And this shows a case where you see the dynamic obstruction, you see the mitral regurg, and some aortic regurgitation. As the procedure is done, we end up with the successful deployment of the clip, and you see the two orifices here nicely on that view. What happens to the obstruction signal? This is what happens. The obstruction is happening because of excessive mobility of the mitral valve. The clip restricts that mobility, and you have a velocity that is almost 5 meters per second aligned within the transgastric view. This is before the clip is deployed. After the clip is deployed, we see early peaking, no obstruction. So it resulted in effective treatment of obstruction. Of course, all the proper measurements needed to make sure that a patient is not left with mitral stenosis should be evaluated in the transesophageal echo before the procedure is obtained. So in conclusion, imaging is essential for the evaluation of patients with known or suspected hypertrophic cardiomyopathy in conjunction with clinical findings. They guide treatment with negative inotropic drugs, with septal reduction therapy, and if needed, the transcatheter edge-to-edge for TEER. The staff in the imaging labs should have clear understanding of the strengths and limitations of the different imaging modalities and clinical implications of findings ascertained by imaging. Equally important, these results should be communicated clearly in the report to the clinical team taking care of the patient so their requests or what they need is satisfactorily addressed in the report. Thank you, and I'm happy to take questions.
Thank you, Sherif, for giving this very comprehensive review of all the diagnosis and treatment of hypertrophic cardiomyopathy, and also reviewing the details from the guidelines. And we have about 83 actually participants from across Ontario and Canada actually participating as well. So thank you for the presentation. I'll start off with one question about Valsalva maneuver. This is one of our most challenging maneuvers that we want to make it reproducible. So because often one person's Valsalva is different than the others in terms of making sure we have the highest gradient. What advice or practical ways that you would give to make reproducible Valsalva maneuvers so we can assess the gradient appropriately, and other imaging tips as well?
Yeah, so it is possible to sort of try to standardize this by noting how much pressure change there is with blowing in a system that allows you to see the actual pressure. I would say that may not be practical for most labs, but the sonographer should show the patient what is a good effort. And some patients will be able to do it, so we want to continue with that. If somebody is short of breath, not able to do it, maybe they rest and you resume again. I tend to guide or to be guided by what is the rest gradient, and I want to see a value higher than that as opposed to identical values. Another thing, if you're having a patient struggling with the Valsalva and they can do squatting to standing, this is very effective and can result in similar or even higher gradients. And so that's another available option for the sonographer scanning the patient.
That is challenging, squatting to standing.
I think we've done that a few times.
Yeah.
Not often.
Do you still use ammonite in the US?
Some labs do. In our lab, we do not use amyl nitrite. It's a matter of practice as far as the Valsalva, I would say. And so if I do it on every case that comes to the lab with that diagnosis, I will get better at it.
Do you use a device to do your Valsalva, or just a patient instruction?
Just the patient instructions. Our sonographers demonstrate to them what is a good effort and they guide them through the procedure.
So Dr. Leon Poi has a question following.
Hi, Sherif. In terms of exercise stress for provocable LVOT obstruction and gradient, would you recommend treadmill stress or post-treadmill stress echo or supine bicycle stress echo, or it doesn't make a difference?
So theoretically, treadmill should result in a higher gradient than supine. And I'll say why. In the upright position, there is less venous return than in the supine position. So the preload is higher when someone is exercising in a supine position. The second thing, afterload is also higher with the bike. Systolic blood pressure is higher with bike stress than with treadmill stress. So with higher preload and higher afterload, one would say the gradient is less the obstruction is less likely to be as bad as in an upright position. Having said that, theoretical difference between exercising in an upright and in a supine position, one study, albeit a small study, showed no significant difference in gradients between the bike and the upright. In our lab, we do treadmill exercise. We do not do the bike for dynamic obstruction. The sonographers will have to be quick in this situation. Once the patient finishes the exercise, they want to acquire the gradient, and they would also recognize that this is the primary focus of the test. Do not look for wall motion. Go for the gradient. Be satisfied that I got the peak gradient post-exercise, if it is the treadmill exercise, and do not worry wall motion.
Yeah, no, thank you. I think that's been our practice as well. But the challenge, as you've highlighted, is to be able to accurately get the gradients in that really short time post stress. Whereas during supine bicycle, there's a bit more time to interrogate, to look at 2D morphology, look at mitral leaflet SAM with exercise, etc. Whereas post stress, post treadmill stress, the time frame is very short sometimes. Thank you.
So, but how quickly actually do you have to acquire it, and how quickly does the gradient actually drops? That's another discussion.
So it's a good point. I do not know how quick it drops. That's the concern, of course. Odds are high it doesn't drop that fast. So there is some time, but in general, as soon as the patient comes off the treadmill, one wants to acquire the signals. If I will say this also, some sonographers are much more familiar with treadmill exercise scanning, much better than supine bike scanning for other indications, say for wall motion problems, looking for coronary disease. If a sonographer is not familiar and comfortable with a supine bike, then asking them to do a supine bike would not be a good idea. If they are, then and there is more information that is sought from the test, then maybe the supine bike. Like I said, theoretically, treadmill and exercising in a upright position has an edge, but in the clinical study that compared both, there wasn't much of a difference.
So another imaging tip that's often challenging is distinguishing mitral regurgitation from left ventricular outflow tract. Do you have any practical imaging tips for our sonographers and us to tell one from the other?
So for all patients, with or without variable degrees of obstruction, I want to scan to show the mitral regurg. I want to align with the mitral regurg itself, not with the gradient, like I showed you in some of the examples. So the reader can see what is the peak velocity for that mitral regurg jet. And then try my best to align with the LV outflow tract, guided perhaps by colored Doppler, but also doing a sweep from the LVOT to the LA, where we transition and we are able to show maybe the gradient by itself, superimpose gradient in MR, and then the MR by itself. If a reader is looking at a study and you are not able to dissect what is the actual peak gradient, and you have a complete MR jet and you have a good measurement of systolic blood pressure, you can include a statement in the report as to what you expect the gradient to be.
Wonderful. That is very useful. Can you further comment on the myosin inhibitors? Because with their introduction in the last 5 to 6 years, it's been really helpful to us. So can you mention this? And then also we have a question in chat after that.
So for the myosin inhibitors, you get a baseline study. You want to know what is the ejection fraction before you start the drug. You want to verify that they have a gradient of at least 50 millimeters mercury, rest or provoke. And there are algorithms of how to dose the drug. We typically start with a 5 milligram dose, and then you bring them at monthly intervals and titrate based on what ejection fraction you get and what the gradient is. Once the patient is on a stable dose, you can then spread that follow-up intervals every 3 to 6 months. The trick I had, not the trick, but the practical thing that I've noticed is some patients, when you do the serial echocardiograms, you can see a subtle drop in EF, and perhaps that should be factored in dosing these cases, so you do not wait till it hits the 50% or lower cutoff before you do something with the drug dose that is.
Yep.
So when I read these cases, I provide a biplane LVEF and sonographers, after they've acquired the gradient, and if they have a patient where it is challenging to see endocardial borders, they will give contrast for us to be able to do the biplane EF.
Yeah, we're starting to have a lot of patients on myosin inhibitors such as mavacamten. We have a question from Sandra, who's one of our frequent attendee. Is also one of the questions we often encounter in our lab. If your patient has a baseline or rest gradient of more than 50 millimeter mercury peak, do you still instruct patients for Valsalva, or what's your protocol?
We do it both. Yes, even with a 50, I would go for a gradient with Valsalva.
And the reason is?
Both are targets for treatment. For example, with myosin inhibitors or with septal reduction therapy. What happens if I don't do the Valsalva before, right? And the patient, say, has a gradient of 60. I give my treatment, whatever it is, we'll say treatment X, and after that, the rest gradient is gone, but I have a Valsalva gradient of 40 or 50. What was it before?
So there you go. Any danger in doing that?
Not really. No.
I guess they do that already at home, right? Okay.
Through their daily, great point. Yes, sir.
Exactly. So any other questions from our Nagueh colleagues or other participants online or in person? Oh, there's one from online again. So do you document, this is a good one. We had a round on this last year. Do you document postprandial period or give patient instructions around eating? Because there's a whole discussion about symptoms after eating, about hypertrophic cardiomyopathy.
It's a great point. I think labs should do that. And I'll tell you an actual case. So this was a patient who was already on mavacamten, was in the, not the initiation phase, but in the maintenance phase of the drug. And that particular patient had no gradients at rest or Valsalva on a fixed dose, which was not a big dose, I believe around 2.5. Then that patient went postprandial as opposed to earlier in the day for her follow-up study. And now pretty high values were obtained. Brought the patient back in a fasting state, and again, we saw similar gradients. So this can add a lot of confusion to the situation and poses management challenges. It is best to use the same state on follow-up at least. And if we do a postprandial at baseline, we want to do a postprandial when we do follow-ups for these patients. And the lab should provide these instructions. Yes.
So in your lab, how long do you tell them not to eat? Or
if it's going to be a first thing in the morning, then it's just in the morning they can take their medications with a sip of water, and then they come to us, and that deals with it. If how long? I would say 4 to 6 hours.
Yep. Almost like doing a TEER 6 hours after. So great. Excellent. So I think, it's coming to the top of the hour. So once again, we want to thank you for all your time and your generosity for sharing your experience and presenting to us about this topic. And for those of you who want to learn more about diastology, there's a beautiful presentation online from the Methodist Hospital as well. They have this great online education. So that's another resource from Dr. Nagueh to share with us. So I want to thank you on behalf of all of us in this lab, as well as across Canada. And as you can see, Sandra is actually from Calgary. So in Calgary is even earlier. So thank you so much, everyone. And we'll see you next week. And seasonal greetings to all of us, or all of you. Okay, thank you.
Take care. Thank you. Thank you. Bye-bye.
Thank you. It's great.